Hello, everybody, and welcome back if you're rejoining us, or welcome to 2030 Insight Live here, live in Nepal. We're in Kathmandu with a global audience, or if you're tuning in, welcome to you, or catching up for a terrific session here. By the way, some breaking news for you. I read the headline from The Rising Nepal: government committed to implementing national eye health strategy, as reiterated by the Prime Minister of Nepal this morning. Yes. So we're already making headlines for the right reasons as we turn our minds now to, yes, global issues, but how do you activate them at a global or rather at a national and a regional level? That's the question for our guests. So let me tell you who joins us. I'll start at the far end, two honoured guests from Laos, and we'll be hearing some case studies from them. I'm speaking there about Dr. Kamkoon Holonapab. Hello, and also Dr. Kamse Detlise from the Director General of the Laos Ministry of Health. Thank you both for joining us. Now, speaking of ministries, Azra Herceg is the former Slovenian State Secretary and former Deputy Minister of Health, and we also welcome Azra into the chair at IAPB for the Europe region. So thank you, Azra, for everything that you're about to do and everything that you've done as well. Next to you, Azra, is Dr. Rita Gurung, who is with the Tilganga Institute of Ophthalmology, and we're so grateful for all of your support throughout our time here in Nepal, Dr. Rita. Thank you. Next to Rita is Tulasi Ravilla from the Aravind Eye Care System, and again, we're so grateful to your colleagues and to you for your support, Tulsi. By no means least is somebody who needs a little introduction round here, and that is Stuart Keel from the WHO, the World Health Organization. We give them all a big round of applause. Welcome. So what I thought is we'll do a sort of three-parter, if it's all right, team. I'll invite you each, either from your seat or a podium, as you wish, to share some thoughts, and I'll tee you up for that. Then we'll have a bit of a conversation amongst ourselves, but crucially, I want to get questions from online and from here in Nepal. Points you'd like to make, questions you've got for each or all of the panel, or things you feel haven't been said, but you'd love to know a little bit more about. So with that, Stuart, a WHO perspective, particularly on data collecting and reporting. Why don't we give another round of applause for Stuart Keel, everybody? Thank you.
Okay, good. That was simple. Hi, everybody. As mentioned, my name's Stuart Keel. I am from WHO headquarters in Geneva, and I lead the work on eye care, vision impairment and blindness in that team. So pleasure to be with you here today. So the idea is for me to set the scene at the global level for then subsequent colleagues to come and... So the three items that I want to cover is United Nations developments for the new eye care agenda over the last 5 years. Then we'll take a quick look at the global eye care targets and indicators, and then what is WHO doing to help support implementation at a country level of these new high-level resolutions. So starting with the UN developments, and this started in 2019 with the publication of WHO's first World Report on Vision. So this really provides a foundation for the new eye care agenda moving beyond Vision 2020. And it does this by creating really a comprehensive eye care narrative as opposed to a disease-specific narrative, and specifically puts forward integrated people-centred eye care as the care model of choice, and suggests that when we're planning for eye care services at countries, we should do so in line with the 4 key principles and strategies outlined on the slide here, which is engaging people and communities, reorienting the model of care to strengthen primary and community level care, coordinating services within relevant health programs such as diabetes, maternal child health, but also across related sectors such as labour, education, private sectors, and then creating an enabling environment for integration of eye care into broader health systems within countries as well. Following this, there was a series of high-level resolutions and decisions at the UN level And this started with the World Health Assembly resolution on integrated people-centred eye care that was adopted in 2020 and really endorses the recommendations of the World Report on Vision. Next came the Global Eye Care Targets in 2021, and I'll be talking about those in a moment. Followed by this, the very first UN General Assembly resolution that really draws on the compelling evidence that improving eye health and preventing vision impairment doesn't just have an impact on the Sustainable Development Goal 3 relating to health, but also impacts other Sustainable Development Goals such as those related to education, poverty reduction, and so on, many others. Then came quite a new resolution that is set to be endorsed this year, which is on primary prevention of integrated sensory impairments. And I encourage you all to take a look at this resolution, which really highlights the importance of early detection of both eye and ear disease along the life course. Looking at the global eye care targets now, in 2021, 2 new global eye care targets were endorsed, namely a 40 percentage point increase in effective coverage of refractive error and a 30 percentage point increase in effective coverage of cataract surgery. Of course, these indicators are linked to the 2 leading causes of vision impairment and blindness in unoperated cataract, uncorrected refractive error. And they're also linked to the 2 remaining public health challenges when we think about eye care. But these indicators, really they are to act as tracer indicators to monitor how the actions and investments in the field of eye care have really delivered on our ultimate goal of achieving improved coverage of quality eye care services. With the sector, we came together with academic institutes and also with NGOs that are responsible for leading many of the surveys to publish the first report on these indicators in 2022. And the new data on these 2 indicators will be published in 2025 at the midpoint of these global targets, and we'll be talking about that in a moment. Mentioned before that these indicators represent tracer indicators for eye care, but they also represent important tracer indicators for universal health coverage more generally. And a key example of this is that effective refractive error coverage has now been officially included in WHO's monitoring framework for universal health coverage in the new global program of work, which really sets the roadmap for global public health work moving forward. So this gives us, again, a good signal that eye care is being taken seriously on the global public health agenda. The last topic now is to talk about what WHO is doing to support implementation of these resolutions and decisions. And generally our work fits in 2 key areas. And the first is the development and now implementation of what we call the Eye Care in Health Systems Guide for Action and supplementary tools. And the second is a relatively new initiative called the SPECS 2030 initiative. And I'll just go into these briefly now, starting with the Eye Care in Health Systems Guide for Action. So this Guide for Action, really over the course of the last 5 years, WHO has engaged with over 300 experts to develop a range of tools to help support planners and other stakeholders through a stepwise process of planning, monitoring, human resource development, health promotion and service delivery. I don't have time to go through all of these items now, but I encourage you to visit the WHO webpage. Many of these are available in different translations, and we're pleased to have had requests from nearly 40 countries now to help support implementation of these tools as the countries go through their process of renewing their eye care strategies. The key focus in 2025 is that we will continue to support countries in their request to implement integrated people-centred eye care, but we will also put a lot more structure around our work with cataract. And this will start with the launch of new data on effective cataract surgery coverage and some new tools for cataract, including minimum quality standards for cataract surgery management, a survey methodology that includes both eye care and hearing care indicators, and a cataract planning and costing tool to support governments to integrate cataract surgery and the cost of cataract surgery within health services packages and policies. And we'll be also working along a more structured approach similar to the SPECS initiative to put some more structure over WHO's work in cataract over the next few years. In addition to this, there is some additional technical guidance that will be published this year on legislative and regulatory issues relating to refractive error. We just came from an important session on the global research agenda for WHO and for eye health, which will be published this year, and also some primary eye care training resources as well. Moving now to the final part, which is the Specs 2030 initiative. We know that uncorrected refractive error is the leading cause of vision impairment in both child and adult populations. We know that there are a multitude of challenges to increasing coverage and access to comprehensive refractive error care and sustainable refractive error care. So this was the time that WHO had decided to take leadership over this and bring together a group of stakeholders over the last couple of years to plan the Specs initiative and strategy, and this was officially launched in May 2024. So it's right on a year since the launch of the Specs initiative. The sole mission of the Specs initiative is to support countries with the achievement of that 2030 target on effective refractive error coverage. So to do this, WHO has 4 key areas of engagement that it has focused on. And if I start from your left on the Global Specs Network, a network of 42 member organisations have now been established. Work plans have been developed, and the key focus of the network is coordinated advocacy and united action around refractive error. In the middle, we have WHO Specs normative work. This is in the context of WHO's normal role of developing technical guidance for countries to help address some of the challenges that they face in increasing coverage of refractive error services. And I'll give you an update on the next slide as to where we're at with that. The third and very important aspect is engaging with the private sector. So the private sector, of course, play a crucial role in refractive error, and we need to seek meaningful contributions if we want to get close to meeting the global target. So WHO has already held a couple of consultations with private sector, and this year we'll be moving forward to seek more concrete contributions. And last but certainly not least, the very most important aspect of the Specs initiative is to bring these contributions down to the country level in what we're doing now. And really the key focus in 2025 is in May 24th, there is a World Health Assembly side event where we will launch new data on effective refractive error coverage and a range of technical tools to help support countries implementing Specs 2030 initiative. The Specs network will move forward with implementing the work plans that have been developed. We will be formalising commitments with the private sector, and most importantly, we'll be supporting country planning and implementation. And the last note on that is that we're very, very pleased with the very strong demand that we've received only 1 year since launch of the Specs initiative from countries. 16 countries, ministries of health, have come forward to WHO with their commitment to move forward with Specs 2030 initiatives. Already been 3 launches. We have had launches in Thailand, in Malaysia, and in India. And very, very happy tomorrow. Please join us at lunchtime at 12:30 in the Kathmandu room, where we'll be formally launching the Nepal Specs 2030 initiative. So with that, I'd like to say thank you. Please get in touch with any questions, any comments, or any ideas. Thank you.
Thank you very much, Stuart, and good luck for that launch moment tomorrow. Stuart, when you launch any support program, especially one supporting many countries, it evolves. You've given us a glimpse of what's coming. How would you sum up how you've already evolved the program to respond to the sorts of feedback you've been getting?
Yes, I think the momentum at the moment is quite strong, and we have had to evolve and really rely on our partners as well. So what we have done is when we are moving forward, for instance, if we take these Specs 2030 country initiatives as an example, what we have been focusing on is strengthening our WHO country office capacity to be able to support government and walk them through at least the initial phases. Yes. And that involves convening local partners and also bringing in the network members as well to help support the actions moving forward.
Yeah. Fab. Thank you, Stuart. More questions for you and others. Tulasaraj, if I could turn to you, sir, because setting the targets is one thing, but then achieving them is another. So we'd love your personal and professional reflections on, frankly, collecting data, what you've discovered along the journey, but feel free to speak from your seat or from the podium. Tilasala's Ravilla, everybody. Please.
So we heard Stuart talk about the global targets. Just a different perspective on the targets. One, for the very first time, I think we have guidance on when to intervene for a condition, either cataract or refractive error. And then what's advocated is that we do early intervention so that we don't allow the patient to slip up on their vision function or quality of life. And then more importantly, I think for the very first time, we have a certain threshold. And when we start implementing this, we'll actually prevent blindness due to cataract and refractive errors. Because till now, this is my thesis at least, that we never had such a direction. So most policymakers actually focused on doing something for the people who are blind. No? So it's almost as if you would let people slide into blindness and then get worried about getting them out of it. Yeah. I'm just showing certain numbers to give where we are now. This is more to kind of recognize the magnitude of the challenge. I think this increase of 30% effective coverage in cataract and 40% in refractive error is to be achieved in the next 5 years. So what it really translates in layman's language is we have done this lifelong work for decades, and in the next 5 years we have to double that work of cumulative. So that's the challenge. And then it might seem like a tall order, but I'll walk you through a few slides to kind of recognize how this can be actually done. So to talk about this in the month of November, we had a very, very intense 2-day workshop, and one of the participants, Rita, is right here, on just taking on this challenge and say, how do we kind of translate this challenge into something that we can say we have achieved it, when the year 2030 comes. So in the workshop, we did come up with some broad strategies and as well as some metrics, which I will run through. I just want to present this data as a case study. This is a population-based study that we had done, which determined that there are about 1,400 plus persons with cataract, as per this definition, of whom 1,098 had been operated, which will give a coverage of about 76%. But once we apply the outcome or the quality criteria, the 1,098 drops down to 775, and the effective coverage drops down to 54. But then what was interesting was that of the 323 who had a poor outcome, 232, almost 2/3, would improve to good vision if they're given a pair of glasses. And that's something that's very doable, and it would have been very doable if you had done this soon after the surgery. And if we did that, then the coverage goes up from 54 to 70%. And then similarly, of those who are not operated, the 348, if you're somehow able to access just 60% of them and then provide them the services with the required quality, then the coverage goes up to 84%, which is that 30% increase. So it is very much in the realm of what can be done. So one thing we have to realize in this is, this requires action from the providers. Now, it is not something that it will take care of it by itself. I think the providers have to do the cataract surgery and do it well, and then give refractive correction if needed. And to do that, I think essentially, to simplify, there are two levels of activity. One is to enhance access. The other is to make sure that everyone who is accessing for the service gets comprehensive and quality care. And together that will result in the enhancement of the target or achievement of the target. And I'll run by some numbers based on real hospital data to give us confidence that this is very much doable. So we took 1 year's data of one of our hospitals and applied the criteria defined by WHO for cataract surgery, which showed that 19,000 people required cataract surgery or would benefit by it. But then when we looked at our own medical records data, we found that less than half had been actually advised. There could be multiple reasons for this, but this is reality. And I would imagine this would be the case in most institutions. And then of those advised surgery, about 5,000 got operated. So we're clearly recognizing there is a gap in diagnosis, there is a gap in compliance, and then we had a reasonable coverage, about 90%. But then of those who showed up for compliance and of those who had a poorer vision, not everybody received the corrective glasses. So with the result that the effective intervention rate, that means of all the people who would have been from cataract surgery, how many got the above the threshold was only 19%. Okay? And all of this is within our hands. So I did a what if kind of an analysis. If we're able to close 50% of these gaps, and you will recognize that it wouldn't require too much effort, if the advice rate went up from 44% to say 72%, and we're able to push up the compliance to 80% with proper counseling and enablement, and then improve the refractive service post-operatively. No, this 19% can become 49%. No, very much doable. And then it is very similar for refractive errors as well. And again, we looked at the data of the hospital. We just took 1 day's data from across the system. We see on an average about 15 to 20,000 patients across our network. And then again, applying the WHO criteria, 3,200 odd patients had refractive error, of which close to 1,600 were wearing the correct glasses, which means the remaining required correction. But then in terms of, so that had a coverage of about 49% if you look at effective refractive error coverage. But then our prescription was only to 566 patients, not the entire 1,633 who would have benefited by it. Again, reasons could be many. So there is a gap in terms of diagnosis and advising. Again, not everyone advised or given the prescription bought the glasses. There's again a gap in compliance. With the result that at the end of the day, with refractive errors, fortunate that in the same day we can actually get the intervention rate, so that 49% went up to 61%. And here again, we see that there is a lot of scope for improvement. And again, I said, what if we're able to close 50% of these gaps? Now that is, more people get advised, and then we're able to push up the compliance from 70 to 85%. Then the coverage rate again goes up to 78%. So all this is certainly doable by the providers. And then the advantage of this is we can actually monitor this literally on a day-to-day basis. Now, because I think only what you measure improves. Now, when you measure, things get done. And with the broader goal of having to go to the community, which would happen only every 5 or 10 years, if at all, we will just not know if you're doing the right thing or progressing, while at a provider level, each one of us can monitor. And then Finally, this question of would the providers be interested, my strong feeling is they would be, because I think there is the feel-good factor that you are providing good quality of vision to others. And then there's also the very practical consideration that this could translate into more revenues for the institution, because early intervention also translates to better paying and more willingness to pay. Thank you.
Thank you, Tulsi. As a presenter, can I just note you finished with 3 seconds to spare, which is always appreciated at 2030 Insight Live. Thank you. Now, I'm also conscious, guests, that there will be questions from these fantastic case studies. So rather than do questions after each, I'll ask everyone to present, and then we'll have questions from you. And if we've got any other time, then I'll spend that asking them questions. But I'll get your questions in after the presentation. So thank you very much, Tulsi. Let's think about national action now. Dr. Rita, I know you've been doing some very interesting workshops. And why don't, as Dr. Rita Gurung takes to the podium, why don't we say a big thank you as well for the Tilganga Institute of Ophthalmology's wonderful support for our time here in Nepal. Thank you, Dr. Rita.
Thank you, Oli. I already asked Tulsi to grade me because the task I was given was what did I do after I went to Madurai to that extensive workshop we all had in November 2024. No. Yes. So we are hearing this from time and again that the prevalence of blindness in Nepal has reduced from 0.84 in 1981 to 0.28 in 2019. Now the National Eye Health Planning and Policies, the government has said, and it has said in its health policy in 2019 that the government actively works with in the eye care in public-private partnership model and integration of eye health into general health system. These are the two things mentioned about eye health in our Nepal Health Policy 2019. So it is the workshop where I was mentioning to you about. So we are working with different international NGOs like the Fred Hollows Foundation, Cure Blindness Project, Vision Himalaya Foundation, Seva Foundation, Good Vision, all those international NGOs, but we were concentrating on cataract, and nothing but cataract. All those partners, and we were screening the community for identifying cataract and bringing them and do the cataract surgery. But after I went to the workshop and I came back, and the first thing I did was, because on Mondays and Wednesdays are residence class, and all the faculties are there, all the residents, all the fellows are in that room, and I said, hey guys, it is not 618 anymore, it is 612, bear in mind. That's what I told everybody. In the refractive error area, what I did after I came back, which I have been talking with my colleagues in Tilganga for very long, but it was not happening, I don't know why. Everybody said, oh, it is difficult, it is costly, but I said, okay, even if it is costly, if we can justify the cost, then that is okay. So before, what we used to do is there is one ophthalmic assistant and few other assistants to go to the community and do the cataract identification. But this time, from January 2025, what Tilganga Institute of Ophthalmology is doing is there is no one OA, but 3 OAs going to those community screening camps, and each and every patient who comes there gets the refraction. And what we started off with is, because we are just starting, we cannot do everything together, so we started selling sometimes and sometimes distributing the presbyopic glasses to the patients needing them. We made a community screening manual where it is explicitly said that, okay, if somebody has got vision less than 612, everybody needs to be refracted and the cause has to be found. So in the comprehensive community screening eye clinic since in the Q1, since January 2025 till date, we screened 21,248 patients in the community, and female were more than the men, and 4,900, almost 5,000 cataract were identified, but the people with refractive error were 11,585. So it is a lot more than the cataract itself. So among these 11,585 patients, 5,433 glasses were distributed, and it was not free. Most of them bought the glasses, and few of them who could not afford, we distributed the glasses for those patients who had refractive error. And mind you, this is just the presbyopic glasses. And we are now working with Good Vision project in Nepal, who specifically works in the refractive error. And in that one, we did the school screening, we did the community screening. And in this project, we are not only prescribing and selling the presbyopic glasses. In this one, we are giving presbyopic as well as the spherical glasses. And if we give spherical and the presbyopic glasses, in that number of patients, maybe 80–85% of the problem is already solved. So only maybe 15% of the patients who did not get the glasses, maybe we have to work on that. How can we, and these are mainly the patients who has got astigmatism, and how can we deliver those glasses to those patients, which we have to work on. In the cataract, again, in Nepal, everybody knows more than 350,000 surgeries are done. And we heard in the morning, in the breakfast meeting, as well as in the ISGO meeting, that many of the patients have refractive error after the cataract surgery because we are inducing the astigmatism. I don't know where do I put these patients, whether I want to make the data looks good and the 612 patients are more, but at the same time, what is good for the patients? Maybe the astigmatism we have created, giving them a good, a relatively better vision for the near vision. In the cataract surgical coverage, now we are implementing effective cataract surgical coverage. Again, this is the outreach we did since January 2025. And the first day post-op vision, the good vision was in 68% of the patients. After 1 week, the follow-up rate was about 90%, and the 80% of the patients had presenting vision of 612 or better. And in 1 month, the follow-up is really low. It's only 55% of the patients got followed up in 1 month, and 86% of the patients got a good vision, which is 612 or better. And 17% of the patients, no matter what you did, they didn't come for surgery. Although we offer them free surgery, but only free surgery is not enough for the patient. There are so many other barriers which prevents them to take up the surgery. As I said, the government is really working on the integration of primary eye care into the general health system of the country. In the strategic plan, which just only told us about in the Rising Nepal, the leading newspaper in the country, now the government has decided that in the 15-bedded hospital, there will be a post of 1 ophthalmic assistant. So he will take care of the refractive error, we hope. From 25 to 100-bedded hospitals, there will be 1 optometrist and 1 ophthalmic assistant. And in 100-bedded or more bedded hospitals, there will be an ophthalmologist, an optician, optometrist, and an ophthalmic assistant. So this is in the strategic plan of the government we are really hoping to implement. And while doing that, in the action, because we cannot implement everything now, so we are asked or requested to train the government staff in eye care. So what we are going to do now. So in conclusion, the process of implementation of EREC and ECSC data collection has started, but there are lots of things to be done for the maintenance of the quality of the eye care. Thank you so much.
Thank you, Dr. Rita. Thank you. And as I say, we'll get some questions when all of our panelists are presented. Just out of interest, Dr. Rita, with that 20,000 sample you talked about, roughly what demographic would that have been age-wise?
The 21,000 we screened.
Yeah.
So traditionally speaking, in those screening camps, most of the adults would come. The children, mainly they don't come because traditionally speaking, but once we have started doing the refractive surgeries, maybe the children will also be attracted, but mostly it is the adults.
Yeah, helpful.
Yes.
Thank you.
Yes.
So examples from India, from Nepal. Now let's get a European perspective. Azra, over to you.
Thank you very much. Good afternoon to everyone. It's a pleasure to be here. And I would first extend my sincere thanks to our hosts because I think the hospitality we experience here is exceptional, and to the organizers for keeping such a large and ambitious event running smoothly. That is no small feat. So before I continue, I would like to acknowledge the inspiring examples we just heard of from our colleagues in Southeast Asia. I think their progress in aligning the national efforts with global eye health targets, from expanding cataract surgical coverage to strengthening access to refractive error services, is a testament to what can be achieved with political will and with coordinated strategy. I think these stories remind us why global commitments matter and what becomes possible when they are translated into national action. So congratulations to you. So let me now turn to a perception I often encounter: the assumption that eye health is no longer a pressing problem in Europe. Everything works over there, right? In fact, just a few weeks ago, a distinguished colleague of mine, a renowned professor of ophthalmology, asked me quite sincerely, "But Azra, what is IAPB focused in EU? We have everything covered, everything works, so why even bother?" Well, he was in for a sermon. Because, you know, this perception, it is not only misleading, it is actually quite dangerous. So, to begin with, Europe is not just the EU, and as a region, it has higher prevalence of vision loss than Sub-Saharan Africa, Latin America, North Africa, and the Middle East. So yes, some Western countries benefit from well-resourced systems, but others, especially in Eastern, Southeastern Europe, remain chronically underserved. And across the entire region, rates of progressive myopia, diabetic retinopathy are rising sharply. Add to that the demographic pressures of an aging population, and the policy response simply isn't keeping pace or isn't even aware of the problem. Every EU member state has endorsed the World Health Organization eye health targets, including those on effective coverage for refractive error and cataract, and supported the 2021 UN General Assembly resolution on vision. These are not symbolic gestures. They are concrete global instruments designed to drive real action. And yet, we continue to see stark disconnect between those commitments and what is actually happening within national health systems. What we face in Europe is not a coordinated strategy, but a fragmented patchwork. Eye health is rarely integrated into national health plans. Few countries report disaggregated eye health data. Even fewer are tracking progress against global targets, like ERAC and ECST. This lack of integration doesn't just create inefficiencies, it costs people their sight. Today, more than 70 million people in Europe live with vision loss. In many parts of Eastern Europe, the situation is especially acute, placing the region as the second most underserved globally after sub-Saharan Africa. This is the result of systemic underinvestment, a shortage of trained personnel, and the absence of comprehensive eye care strategies. And this is exactly why IAPB and its members launched the European Advocacy Network for Eye Health in 2024. Our objective is ambitious but clear: to elevate eye health as a political priority across Europe, to unify fragmented advocacy efforts, and to align national and regional work with global frameworks led by WHO and endorsed by UN and the World Health Assembly. We are already seeing progress. At the WHO Regional Committee for Europe, we successfully advocated for integrating eye health into the framework for resilient and sustainable health systems 2024 to 2030, explicitly linking vision to universal health coverage, inequality reduction, and systemic resilience. At the EU level, our European Parliament engagement strategy has identified key policymakers in countries like Cyprus, Ireland, Portugal, Slovenia, and Spain. Engaging the EU Parliament is planned for this May, with tailored engagement strategies to bring eye health to the forefront of EU discussions. And through our collaboration with WHO Europe for World Sight Day 2024, we reached more than 2,000 UN employees and 200 school children, sharing inclusive educational materials and raising awareness about the importance of early intervention and accessible care. There are encouraging examples from individual countries, so not everything is bleak. France and Germany are working to integrate eye care into the universal health coverage frameworks. Hungary has made cataract quality a national focus. And in Slovenia, my home country, I can say we offer comprehensive eye care through our universal health coverage system, from systematic screening for newborns and school children to full coverage of intravitreal treatments for macular conditions. We are also moving toward national screening for diabetic retinopathy. But let's be honest, across the region, these examples are sometimes maybe more exceptions. And even where they do exist, the systems are stretched thin, often struggling with long waiting times due to limited funding and resource constraints. So where do we go from here? As we approach the next global summit, the European network is focused on 4 priorities. First, we aim to engage high-level leadership. We are preparing to launch the European Friends of Vision Group to bring together heads of state and senior decision makers under a shared vision of equitable eye care. Second, we need to raise public and political awareness, especially around the importance of early detection of major causes for vision loss, like refractive error, diabetic eye disease, and age-related conditions. We must also confront a worrying trend. In many high-income countries, and I don't mean just inside Europe, vision has become a commodity rather than a public good. In some places today, it's far easier to schedule a refractive surgery in due time than an uveitis follow-up examination. As providers prioritize high-revenue interventions over complex care. Third, we need sustainable financing. That means working with WHO Europe and other partners to connect eye health to economic development, to make the case for investment through the lens of workforce productivity and human capital. And fourth, we must close the data gap. Without solid data, there is no accountability. And without accountability, there can be no meaningful policy change. So let me end with this. Vision is not a privilege. It is a fundamental human right. And blindness especially when preventable, is not just a health issue. It is a social failure. And as Helen Keller once said, the only thing worse than being blind is having sight but no vision. We now have tools, targets, knowledge. What we need is a vision and the political will to act. And I think from London to Lisbon, from Kyiv to Podgorica, Reykjavik to Bucharest, no one should be left behind in the dark. So, thank you very much.
Thank you, Azra. Azra, as you retake your seat, you're a former Deputy Minister of Health. What do you say to guests who have a health ministry in their sights and really want to get eye health up their agenda? What's a practical tip to do that? Because you've been on both sides of the table.
Does this work? Yeah. Well, actually, I would invite them all to the next masterclass we're having on how to formulate an effective policy ask, because we're going to go much deeper into that. But what you actually need is the knowledge on how to actually present your ask to a policymaker, because sometimes they do not speak the same language, and you can come equipped with all the data, all the arguments, and you just won't get across. So, well, to be quite honest, it helps to know someone, but lacking that, you have to speak a politician's language. So you have to frame it in the way that is interesting for a politician, either through data and economic impact of what you want to implement, or by addressing some SDG or something like that, that is currently a buzzword in your country.
Yes, thank you, Azra. I know we could get lots more from you. Azra may be available in all tea and coffee breaks for more advice. This is really valuable. Thank you. Well, we have a director of a Ministry of Health here. In fact, we have two colleagues, again from Southeast Asia, from Laos. So we'll hear from Dr. Kamze in a moment. But first, let us welcome to the podium the director of the National Ophthalmology Centre, Dr. Kamkun. Very good for you to be with us. Thank you.
Good afternoon, everyone. I'm from Laos. Yes, the slide.
Well, just a moment, Kamkun. We'll get those lined up for you.
Okay.
Yeah, Kamkun, we're going to try and get those online. I'm conscious we've had some terrific presentations already. I'm very happy to get a question or two in while we're front loading. I see you there in that second row, sir. Thank you very much. If you've got another offer for me, we'll get a microphone straight down to you. Colleagues may be busy, so I'll take it. Feel free to say who you are, but you don't have to. Welcome.
Just a question to the previous speaker who spoke about the situation in Europe. And as I heard, that condition is not that rosy in the Eastern Europe. But I'm talking about the Western Europe. Why is that? That in a country like Nepal, if a patient comes with cataract in a public hospital or in an NGO hospital, he or she gets an appointment for surgery within a day, 2, 3 days. Why is that even in the Western Europe, one has to wait for cataract surgery for many months? So much so, let me tell you, I operated some patients coming from Western Europe because they could not get an early appointment for cataract surgery there. And has there been any study as to what is the impact of that on patients' productivity, their emotional status for that delay
Good question.
for cataract surgery?
Yeah.
Thank you.
Thank you, Azra. You're being put on the spot on behalf of thousands of colleagues there. An initial response.
Well, you brought up a really good question, so thank you for that. It relates to one of my points in this, during my speech, that in some countries we prioritize some other interventions maybe sometimes. But as regards to cataract surgery, we might have some quite high thresholds for when the cataract surgery is indicated. In Slovenia, it is, I'm sorry, I will be relating to the Snellen 07 vision. So that is like, if we talking, it's 8/12? Yeah. Oh, 6/12 is 05. Yeah, so probably 6/9. At least it is in Slovenia. And it comes down to the healthcare fund financing and funds allocation. Because, for example, in Slovenia, we have universal health coverage that is financed by the National Health Insurance. And they predetermine a program of how many cataract surgeries will be available in a year. And as you can probably see, the problem comes down to that you can't really predictably predict how many patients will develop cataracts. And also to the funds allocation as a whole, because we are also financing the intravitreal therapy, which is quite expensive, and some other rare diseases. And all that must be divided inside one budget.
Yeah. Thank you, Ezra. There's lots more that could be said on that, so we can always return.
I could speak for years, probably.
Dr. Kamkun, thank you for your patience. Over to you.
Sorry to my delay. Okay, just come. Okay, it is a pleasure to share our experience with the eye care situation analysis tool, or ESEC, they call ESEC in Lao PDR. Today we will walk through how we apply the ESEC to assess our eye care system and guide for future planning. For this slide, this section addressed the policy and institution context that enable ESEC to happen, and strategy and partnership to alignment with the broader health agency. The process of the ESEC to implementation and what made to effective. For this, the last national survey of the eye care indicator that's allowed, 11% people are blind and have the low vision. We have the national eye healthcare that's come in the end of this year. And with the last assessment and the health system to work, conduct more than 10 years ago. For those of you who will not know, the ESEC is the eye care situation analysis tool that is developed by WHO. This tool allows you to assess in the building the block of the health system. This is the tool. It has been used globally and provide a framework that can be used locally and aligned in a health response with local and regional and global priority. To be able to reverse some of the conditions that were in the place in the success implementation of ESEC. The Ministry of Health demonstrated strongly to leadership and priority of iHealth and demonstrate in the development and endorsement of previous national iHealth policy. In Laos, we also have the increasing the activity to a care working group. This is the making of key stakeholders from the iHealth sector, and it plays a key role and engagement of the implementation of the ESEC and in the coordination of activities. We also recognize in the importance in framework iHealth broadening, linking to education, aging, disability, inclusion, and NGO. And then Ministry of Health to formally to request the technical support from the WHO undertake of the ESEC process, discredited ownership and engage key partner. We convene and inception and meeting and divide range and stakeholders from the Lao iCare working group and technical group and are formed in oversee the process of maintain alignment. A national consultant from Dr. Chandavon Posai, we engaged in the management data correction and analysis and dissemination. The APB and the WHO also played an important and provide technical input in the ensuring the process met quality standard. And our approach was systemic from the beginning. At the inception meeting, we agreed the comprehensive list of the stakeholder and data sources. We applied the ESEC across the 6 WHO health system in the building blocks to ensure the holistic view of the system. All the key stakeholders were involved through interview, we focused group discussion, and creating a strong evidence base for analysis. Yeah, it's this part, and I finish and continue to my colleagues, continue the part 2. Thank you.
Thank you, Dr. Kem Kueng. Nice shout out there, Stuart, for the WHO support. Very interesting phrasing on broad framing as well. Really powerful. Thank you. Dr. Kamsey.
Good afternoon. Thank you. My colleague, Dr. Kem Kueng, already talked about the access. So now I will talk about how we move forward from assessment to action and how access finding are shaping and real change in Lao PDRs. This session focuses on, first, the inclusive participatory nature of the workshop and its outcomes. Second, how access finding are feeding into the National iHealth Plan. Third, lesson learned and a call for replication and regional report. So in February this year, we have a national validation workshop with broad participations, including government, NGOs, education, finance, workforce planning, and civil society organizations. We also had participations from the capital and the province and from different levels of the healthcare systems. The majority score from the access were discussed and agreed upon collectively. The majority score in an access give an indications of which area of the eye health system don't need any improvement, which needs some improvement, and which needs significant improvement. On this slide, there is an example of maturity scores for each of the 6 building blocks of the health system and for each of the components of each building blocks. The workshop has helped identify both system strengths and key areas for improvement. We went through each of the building blocks of the eye health system and discussed strengths and needs. When then collectively agree on what the key priority should be, for example, workforce planning, integrating pediatric eye health services, and infrastructure and equipment. The findings from the access process will inform our next national eye health plan, making sure that it is evidence-based. The access also propose concrete action that we can talk to address the priority implementation plans. These actions are now being considered for inclusion in our national strategic and implementation plans. Importantly, we are integrating monitoring and evaluation mechanism into the new strategy. These monitoring and evaluation systems are directly linked to the priority that emerged from the access finding. This will help us track progress and remain accountable. On the second day of the workshop, we focus on the system thinking. This will design to strengthen participant understanding of system leadership and complex problem solving. The sessions help stakeholders explore new approaches to address systematic challenges such as workforce retention, infrastructure gaps, and service integration. Participants will also introduce the 2 practical tools they can use to apply system thinking in their daily works. This section of the workshop was facilitated by Anna McCann, the IAPB Director of Capability Building. Overall, these 2 days process help build shared understanding and stronger foundation for collaboration action going forward. The access served as a catalyst for national engagement. It brought together stakeholders in new and productive ways. The process we follow is not only useful in Lao areas, it can be adapted and replicated in other countries across the region. Based on our experience, we encourage others to consider a similar approach to their own eye health systems. So it's on for my presentation. Thank you.
Thank you very much indeed, Dr. Kamse. Well, if you're just joining us in the room or just tuning in, our theme here is about activating global issues at a national or regional level. We're very grateful for some excellent case studies. And we'll open it up to the room. You might have a question for one specific guest or for more. If you raise your hand, we'll come to you. Thank you. Right in the middle there. We'll go halfway back and then towards the front in the yellow shirt. Thank you. Feel free to say who you are. You don't have to.
Thank you. This is Poonam from CBM Global. So I have a couple of questions, one for Aravind Tulsi and also Tilganga Rita. I'd be interested in hearing about the reasons why in the brilliant presentations that you made of your services, what were the reasons that you encountered for people not being advised for cataract surgery, and the reasons for poor take-up of surgery once people were advised? So, what were those barriers, and perhaps we might have the same that we can address, and how did you address those? And a question for the colleagues from Laos, because we also work in Laos. What is your timeline for completion of the EXAT? I'd just be interested to know.
So your
Thank you.
timeline for completion. All right, so that first question on that difference there, Tulsi, would you mind?
I'll take that. I think this is the first exploration, so we're not 100% sure. But then what I'm quite sure is that there is a lot of practice variation. I think each doctor or a provider, as to when they advise intervention, I think it varies. I think that is there. And quite often, I think we have not looked at such data in the past. Because usually it is one patient at a time. You do whatever you think is right. This big picture was not there. So this is the first time that we actually looked at the data. And of course, the initial reaction was denial. Why would we not advise? But then the reality is there. I'll tell you what you're planning to address this. One is sensitization, letting the people know about this new threshold, like Rita went back and spoke to the doctors. Second is, since now in most of us use digital health record, EMR, we can actually have an alert pop up to say, this is a patient who should have been advised, but you haven't. Is there a reason? Just to alert them. So I think that would fix it to a large extent, I think.
Thank you, Tulsi. Rita?
Yes, I think it is the, again, sensitization of ourselves, our fraternity, rather than anybody else, because so far we are used to saying that when the vision goes really bad, then we advise the patients, but now the threshold has already changed to 612. So we have to change ourselves to tell the patients that, that now this is the time you have to. And the other thing is the service providers also have to be very confident that if the patient wants to have the surgery at 618, don't make it 624 or 636. We have to make it 612 or 69 or 66. So we have to also have the confidence, the training and everything will make us confident that we can afford the services, cataract services early enough to the patients.
Yeah, thank you, Rita. Let's get the question at the front of the room here. As the mic comes over, Stuart, I am going to come to you about data and how we increase its accuracy, what we can do in the room to drive that up. But let's hear from our guest. Oh, forgive me, sir, just hold for one moment. There was a question for our Laos colleagues about timeline. Forgive me, sir.
Okay, thank you for your questions. As I mentioned in the presentation that we start in February to conduct the evaluation, and after that we used 2 months to complete the questionnaire and review the questionnaire, and after that we try to make the report, but until now the report undergo and go to the finance version of the report.
Okay.
Thank you.
No, thank you very much. Question from our guest.
Thank you. I'm Dr. Ashraf from Indonesia. I also want to ask to Dr. Tulasiras from Arifin and continue with the previous question. Surprisingly, that if we count that the patient who came to our hospital and our service, and in your data that show us the eligible cataract and also the advice for cataract is less than 50%. So I think it's make a new perception for us. My question is there any concrete solution to increase how to reach the eligible or advised cataract to increase the number of the patient to be operated?
Yes. This point about access.
Yeah, but I mean, I did a hypothetical kind of assumption that if you're able to close 50% of the gap. I think it can be done. I think today, because this is quite new. You know, like I would bet if you go and ask many of the doctors about what is the threshold for intervention for cataract surgery, many would not have really an answer. You know, they might say 660 or you know, they may say some numbers. So I think the huge gap is not having that knowledge, you know. And like Rita also said, the confidence about doing better than the pre-op vision, that's also a real concern. And it's an issue of sometimes the skill, the equipment that you have, and also the kind of IOLs you can get. I mean, can you get that exact power IOL that you want? Sometimes there are challenges in that as well. No, so there are multiple things, but I think, but to me, I think what we can recognize is that all of these are solvable problems. No, so I think to get to a much higher level of coverage is something which is very, very feasible, because almost everything is under our control. Yeah. But these are patients who already come to us, now where we have like a missed opportunity.
Yeah.
So that to me is a huge opportunity that I think all of us should kind of work on. It will take time, but I guess if we really apply our minds in 6 months or a year, I think we can be in a very different place.
Thank you, Tulsi. Stuart, can I come to you on that data point, increasing its accuracy? What can we do in the room to really keep driving that up?
Keep driving the quality
yes.
of... Yes. So if we look at the data from a global level, the sector has done a great job actually of rallying together since the adoption of these global targets to get reasonable estimates in place. And that is going to improve this year. I think there's been a 30% increase in the amount of data we have got to report on these indicators in the last 2 years, which is a significant increase in data. So currently we have data from about 80 countries, also spanning back about 15 years. And this level of data and the work from the academic sector in eye care, but also the NGO sector to really drive this data through the system to WHO has allowed us to now elevate these indicators within the UHC framework as an example. But still, we need to maintain this and we need to build on this. And what we are looking at doing at the moment is adopting similar approaches to what Tulsi had presented and looking at feasible indicators that can also be used as proxies towards these sort of gold standard global indicators. And we have started engagements on that, and hopefully very soon we'll be presenting some sort of new approaches to enable more feasible way for countries to present this data. But we encourage you still, of course, to do your intermittent periodic population surveys where it's feasible, but there may be some other solutions as well with more readily available data moving forward.
I suppose in other areas, if you think about Alzheimer's, cancer, you've seen some quite interesting partnerships with the private sector. How, I wonder about that potential.
Yeah, that's a very good point, and that's the top of our agenda when we talk about the SPECS 2030 private sector engagements. One of the key items that we have put to them is to provide data from the private sector, and that talking about the European region where we don't have a lot of data on effective refractive error coverage could really fill a significant gap as an example.
Right. Now, what I would like is another 20 minutes to keep talking, but the one thing that I have to respect in this packed 2 days is our schedule. So forgive us. If I could persuade you to stick around for our 15-minute coffee break, that would be lovely, because I know there'll be conversations to continue. But to each and every one of you, firstly, a huge round of applause. Thank you very much. Brilliant guests. Thank you.